Namaste. I'm Dr. Siddharth Oskhati, International Trainee Registrar in Emergency Medicine. I'm undergoing hybrid international emergency medicine training at Chitwan Medical College, Nepal. The title of my audit is Completion of Checklist for Rapid Sequence Intubation by Healthcare Workers in Emergency Department. This is the first of its kind here in our hospital. And the title of my thesis is Utility of Modified Early Warning Score (MUSE) in triaging and outcome prediction in patient presenting to emergency department of Chitwan Medical College. I would like to continue my quality improvement project on rapid sequence intubation checklist. Before going to details of my project, I would like to share a story of Mr. Birkha Bahadur. He is a 65-year-old male who lives in the outskirts of Bharatpur. He presented to the emergency department in a gasping and unresponsive state. At trials, his oxygen saturation and blood pressure could not be assessed. His lips were blue and he was not able to complete a full sentence. He was then soon transferred to the resuscitation area where an immediate help was made and was started on bag and mask ventilation. Definitive airway was planned and the whole process went smoothly. But soon after the procedure, ECG on the monitor showed bradycardic rhythm and eventually his pulses were not palpable. And later, monitor's ECG showed asystole and cardiac arrest was declared. High quality CPR was started, but alas, he couldn't be revived after half an hour of CPR. This story could be of one of us. Mr. Birkha could be of one of us and our loved ones. What best care should we have given to Mr. Birkha, which could have saved him? What did we miss? If the checklist for intubation had been used, then it could have saved him. If triaging had been done with the help of MUSE, would it have bettered his outcome? This is the reason I am doing my project on this topic. I am centered to provide quality care to patients like Mr. Birkha. By definition, intubation is the insertion of ventilation tube into the trachea for artificial respiration. Now, reviewing the global statistics, tracheal intubation is a high-risk procedure in critically ill adults, and 20 to 25% of patients experience cardiovascular collapse defined as hypotension, new vasopressor use, cardiac arrest, or death during or immediately after the procedure. In the UK, a quality improvement project by Cameroon quoted that the completion of intubation, that is inability to oxygenate, aspiration of stomach contents, cardiac arrest tends to occur 30 times in the emergency department than in operation. And the contributing factors include not identifying potential difficulty prior to the procedure, not assembling the correct equipment, failure to determine backup plans in case of failure, and intubation by personnel without sufficient experience. In Asia, there is a study done in South Korea where post-intubation arrest occurred in 4% of all patients in the ED, and hospital mortality rate of patients were 84% after return of spontaneous circulation. A study conducted in India quoted that the incidence of difficult intubation was 8%, and the intubation which was lead to pulmonary aspiration of 4% and the mortality of 3%. There are other numerous studies that have been done to identify the complication associated with rapid sequence intubation and the solution. However, little research about it is done in Nepal, which demonstrate to do further work. In fact, various checklists for intubation are developed, and one of them is from Royal College of Anesthesia, which would be beneficial to provide structured approach to procedure and allow cognitive offload in potentially high-stress circumstances. But still, in tertiary hospital, the dilemma of successful intubation and triaging persists. Maybe could this be a factor in Mr. Birkha's suffering? So, I planned and designed to implement the completion of checklist for rapid sequence intubation in emergency department by healthcare workers developed by Royal College of Anesthesia to provide quality care and resuscitation in patient needing intubation. So the aim of my project is to make recommendation for improving the maintenance of intubation checklist to facilitate effective rapid sequence intubation in accordance with the quality standards as suggested by Royal College of Anesthesia. I plan to manage efficient team in order to manage rapid sequence intubation, revising the training program to support core providers to provide rapid sequence intubation by preparing the patient, preparing the equipment, preparing the team, and preparing for any difficulty. Furthermore, I will help to build up the confidence in the team by providing guidance, practical sessions, and simulation session. I will develop strategy to work with the stakeholders like doctors and nurses and emergency and critical care physician, and also like to analyze the fishbone analysis for identify the root cause. So as a whole, the purpose of my project is to save life. Thank you.